Hi, everybody. You know that we're with some great people this morning who are going to talk to you about accelerating access to long-acting injectables for HIV treatment. And I'm just going to take a minute to embarrass them and tell you some great stuff about them. Dr. Jason Zucker is an assistant professor of medicine in the Division of Infectious Diseases at Columbia University and assistant medical director of the New York City STI Prevention Training Center. Dually trained in adult and pediatric infectious diseases, he provides status-neutral HIV and sexual health care across the lifespan at the NYP Columbia Comprehensive Health Program. His research focuses on the intersection of data science, behavioral science, and implementation science, identifying and developing ways to optimize engagement in the sexual health cascade of care for individuals both living with or vulnerable to sexually transmitted diseases. And I could say more, but I'm going to go on. Dr. Katrina Meyers, the RPH, is an associate professor of biobehavioral sciences at the Aaron Diamond AIDS Research Center in the Division of Infectious Diseases. She is a social science devoted to addressing health inequity by accelerating access to proven therapeutic, preventative, and diagnostic interventions by marginalized and underserved populations. And again, I could go on with a huge CV for all of these people. Next is Dr. Castor, PhD, is an assistant professor in medicine and epidemiology, Department of Medicine, Division of Infectious Diseases, and Department of Epidemiology here at Columbia. She is also director of the section on health equity in dissemination and implementation sciences in the Division of Infectious Diseases. Dr. Castor is an epidemiologist who studies how to introduce and scale proven infectious disease interventions in public health programs for population-level impact. She joined the faculty of Columbia in November 2019. And Nguyen, PhD, is an associate research scientist at the Aaron Diamond AIDS Research Center. Her research aims to improve engagement in HIV prevention and care through the introduction and implementation of novel biomedical interventions, including mobile and point-of-care technology and long-acting HIV prevention and treatment modalities that empower patients and providers through actionable feedback and choice. And she was, and of course, a very beloved HIV Center fellow before joining ADAR. And now I'm happy to turn it over to you.
Thank you, Bob and Susan. I'm trying to minimize windows. 1 second. All right, so you will meet all of us. Oh, all right. I have to share. I think I have to go out to share. No? No, it's not. All right. Sorry for that. So you will meet each of us in turn. We've just been introduced. I'm going to turn off the closed camera. I have to start with this funding acknowledgement that our funder, the HRSA, requires us to put in all of our presentations. The contents are those of the presenters, and they may not reflect the policies of the US government, particularly at this moment in time. The agenda is going to start. Jason is going to take us through an introduction to injectable HIV treatment to make sure we are all sort of on the same page about what injectable HIV treatment is. I'm going to provide an overview of the Ally Up project about which we are speaking today. Then I'm going to turn it over to Delavet to talk about one aspect of our monitoring and evaluation, which is the clinical monitoring piece. And then Nadia will talk to us about one aspect of our community engagement work, which is around quality improvement. And then leave time for us to tell you a little bit about how we're trying to synthesize the lessons that we're learning from this service delivery project and hopefully engage in a lively discussion. So with that, I'll turn it over to Jason.
All right. Morning, everybody. All right. This is great. So thanks for all joining us today. And those of you in person, it's great to see everybody again for the first time in a while. I'm going to start by apologizing in advance. This is going to be an awesome talk, but I'm going to have to sneak out early to go catch a flight. So I promise I'm not leaving because I think the next part's going to be bad. So I'm going to be talking about long-acting injectable therapy, often abbreviated LAI-ART. As the clinician on the panel, I'm going to walk through what these medications are, the data behind them, both clinical trials and real-world evidence, and then a little bit about what the future may hold. And the goal is to just give you an evidence-based perspective on these medications. And we'll start with the basics. Long-acting injectable ART are injectable HIV medications that suppress HIV, and they have longer half-lives than oral medications, reducing the frequency of administration. These medications can be used for either treatment or prevention, just like oral antiretroviral therapy can. And today's focus is specifically on treatment. Katrina is smiling as she has specifically instructed me to make sure we know that we're talking just about treatment today. In terms of what's available, there's currently only one complete approved long-acting injectable regimen, and that's cabotegravir combined with rilpivirine. Cabotegravir is an integrase strand inhibitor, similar to some of our other medications like dolutegravir, bictegravir, or some of the earlier generation ones like elvitegravir and raltegravir. Rilpivirine is a non-nucleoside reverse transcriptase inhibitor that's been used a long time in its oral form for HIV, and they can be injected together every 1 to 2 months. There is one other medication that is approved. This medication is approved for multi-drug resistant HIV. And as a single drug, it has to be combined with other forms of antiretroviral therapy. And this is lenacapavir, which is a newer class of medication called a capsid inhibitor, which doesn't have cross-resistance with the other medications. And it's injected every 6 months. Did I say something wrong? Oh, okay. I mean, someone made a face and I got nervous. Again, we're not talking about HIV PrEP today, but both cabotegravir and lenacapavir are the two that are approved for HIV prevention if it comes up. So what do we know about injectable cabotegravir rilpivirine? So I like to say that this goes back to the beginning. In the beginning, there was FLAIR. And the FLAIR trial was a clinical trial that looked at people who were HIV treatment naive, so newly diagnosed or just starting therapy for the first time. They had to take oral medication first to become suppressed, and then they could be randomized to either continue on oral medication or be randomized to get injectable cabotegravir rilpivirine every 4 weeks. And the trial was a success. Injectable cabotegravir was non-inferior to an oral regimen for maintaining HIV viral suppression. So we know that at least in people who can take their medications, who had not received any treatment before, it was equivalent or non-inferior. And they followed these people for quite a long time to really prove that. They actually have 96-week follow-up. And it did not demonstrate any sort of increase or no new episodes of virologic failure at 96 weeks. And then the 124-week follow-up. And this is where we have a little bit of a switch. No, sorry, that's the wrong study. Yeah, we're going to leave it right there. Sorry, I'm confusing myself. All right, so 124-week follow-up, similar to the same thing. Atlas and Atlas 2M was another study that was very similar. So the Atlas trial was for people who were not HIV treatment naive. So these were people who had been previously on HIV therapy, but were also undetectable for at least 6 months. And when they were randomized to either stay on their oral therapy or switch to injectable cabotegravir, they again found that it was non-inferior for people who are not treatment naive. One of the tricks to the Atlas study is that after they did this, there was a question about whether 4 weeks was really the right interval. And there was some PK data that suggested that you could actually go to 8 weeks. And so they actually modified this study for longer term follow-up and gave people the option to then be randomized into every 4 weeks or every 8 weeks. And not surprisingly, almost everybody, all but 56 participants, chose to be randomized into the every 4 versus 8 week arm. And so there is not great 96-week follow-up for this study because most people switched into the Atlas 2M study. And what they actually found was that the efficacy and safety of every 8-week dosing and 4 weeks were similar. And so every 8 weeks were similar to every 4 weeks. So we have data that supports long-acting injectable therapy, and these people were followed actually out to 96 weeks, and again, did very well at every 4 versus every 8 weeks. The one caveat being is that there was a small increase in the number of failures in the 8-week group compared to the 4-week group. And we'll talk about that a little bit in a second. So this is kind of what we have now. We have data that supports long-acting injectable ART in naive patients and experienced patients who are starting at undetectable. And that's how we got the package insert or the approval for this particular drug. And again, package inserts become very important, especially when things are expensive, because that's often what insurance companies will cover. And the package insert for this drug suggests that for virologically suppressed individuals on stable antiretroviral regimens with no history of treatment failure and no known or suspected resistance to either CAB or rilpivirine. So this is who can sort of get this easily at this point in time. But in the real world, many of us have patients who don't necessarily meet this criteria, but would probably do very well on this regimen. The other thing to keep in mind is in terms of resistance. There's a lot of resistant mechanisms that are listed on the package insert, not all of which even show up in the Stanford database. And most of these people were actually excluded from many studies. So we actually don't know how they would do in the real world, which is just another challenge that we have to face here. Some things to think about when it comes to the resistance, in the pooled analysis of Atlas and Flare, at 48 weeks, there were 6 patients in the injectable arm who had confirmed virologic failure. All of them had NNRTI resistance and 4 actually had integrase resistance. The good part of that, though, is that the integrase resistance was primarily to first-generation integrase inhibitors. It was not to dolutegravir. So it does maintain the ability for us to use what we would consider a first-line therapy for these patients. At 96 weeks in the Atlas 2M study, they found 11 patients with virologic failure. Again, very similar to before, with most having NNRTI and INSTI resistance, but only 2 were in the every 4-week arm and 9 were in the every 8-week arm. Again, suggesting slightly higher failure rates in the every 8-week arm. And so that takes us to our package insert and sort of how we got where we are today. We need to understand how we want to best handle this in the real world. So from Flare and Atlas, we learned that cabotegravir and rilpivirine are highly effective in people who are undetectable and people who can already adhere to therapy. We learned that 4 and 8-week dosing intervals are acceptable, although there's likely a slightly increased failure rate in the 8-week arm. When failures do occur, resistance is very common to both NNRTIs and integrase inhibitors, but not to dolutegravir, which again is important when we think about what our other treatment options would be. And finally, because many of these very common resistance mutations were excluded from the studies, we actually don't know how people with those mutations would fare receiving this drug. And so, it's time for us to think beyond the package insert about what we can do for additional people. And to do that, we do have one study that is the Latitude study, which extended this a little bit. We talk about the Latitude being an amazing study, and it is because we enrolled people with adherence challenges. But when you hear about the study design, it only extended our ability to give this drug a tiny bit. And that's really one of the challenges. This was A5359, so an ACTG study, that looked at whether it could help people with non-adherence. However, the challenge of this trial was that there's this step 1 that you can see up there. Sorry, let's see. Can you see that? There's step 1 here. And step 1 actually required people to start on oral therapy and then get undetectable before they could be randomized into the injectable or the oral arm. To do that, they also added lots of conditional incentives, financial incentives, support, and other things. And so it's something that A, may not be replicable in the real world, and B is a challenge because one of the reasons we think long-acting might be right for some of these patients is they're not good at oral adherence and they're not necessarily able to get undetectable in the first place. And so this was an amazing study and enrolled a challenging group of people. but only partially answers the question we have about could we use long-acting injectable in people who really need it and maybe can't get suppressed. This also study was not only interesting to do, it had an interesting sort of outcome as well. The primary outcome was regimen failure. And you can see here that the time the study was stopped, there was a difference, 24% regimen failure in the long-acting arm versus 38.5% in the standard of care arm. And the confidence interval just crossed 1. And so it was not necessarily significant. But because virologic failure and treatment-related failure were such big outcomes in this study, the DSMB actually stopped the study early due to superior efficacy of long-acting cab and rilpivirine because of secondary endpoints. And I can't think of too many trials I've seen stopped early because of secondary endpoints. It's a little bit unusual, but I think it really does reflect the difference that you can see here. In terms of virologic failure, it was only 7% in the rilpivirine arm versus 25% in the standard of care arm. And treatment-related failure, 9.5% in long-acting rilpivirine versus 26% in standard of care. And these are really large and meaningful differences in a group of people who were traditionally not able to be suppressed, who are starting with lower CD4 counts and are treatment naive or are previously undetectable patients. And so a group that really needs it. And so I do think the DSMB was right to stop it early. It's just sort of an interesting approach to this. And because of those findings, IAS updated their stance on this. Previously the recommendation had been essentially to follow the package insert. But based on Latitude, IAS really said that, when supported by intensive follow-up and case management services, injectable rilpivirine may be considered for people with viremia who meet criteria below when no other treatment options are effective due to the patient's persistent inability to take oral ART. So patients who are unable to take oral ART consistently despite extensive efforts and clinical support, high risk for disease progression, and virus susceptible to both rilpivirine. And then if applicable, refer for treatment of substance use disorder or mental health, because these are some things that contribute to patients not being able to be on therapy. And I think it's really important that they're recommending this because it's a recognition that yes, there's a risk of resistance, but when weighing the risks and benefits, the benefits of getting people's viral loads down and putting them on long-acting cab with only 7% failure rates is immense. And so I think that's what we're really seeing here. What do we know about this in the real world? Well, interestingly, there was just like a week ago, a publication from Chloe Orkin that did a systematic review of 14 observational cohorts, including 561 people with viremia at initiation. We were joking earlier, there's no great figure in this paper that I can put in here, and so I apologize for that. So it's just a lot of words. But across the 561 people, they had 36 virologic failure events in 11 of the cohorts. Virologic failure rates were 0 to 25%, but again, some cohorts are very small. In the cohorts that were greater than 100 patients, the virologic failure rate was 4%. Again, putting it right around that 7% range that was seen in the Latitude study. In terms of genotypic data, there were 14 virologic failures that actually had resistance, the majority with NNRTIs, some with integrase inhibitors, and then 8 of 14 with dual class. Again, not necessarily with dolutegravir resistance, though. And that's really important to keep in mind because dolutegravir requires 2 mutations to develop resistance, and it's still susceptible, and we can still use a first-line agent for these people. Post-virologic failure management was really interesting. A lot include lenacapavir, which we're going to talk about on the next slide. And some people just actually continued long-acting cab and rilpivirine with people who actually then resuppressed. In terms of discontinuations, there were only 35 events out of 561 individuals across different studies. And so, these studies did not yet have a long enough follow-up, but that, virologic failure was fairly low, 4% in the cohorts greater than 100 people. Resistance to virologic failure is common and something we need to think about. When people do fail, we need to then carefully think about what regimen to put them on next. The outcomes are not totally clear yet, again, due to time. And the evidence does support cautious use of this drug in those patients, especially if you think they could benefit from them. So now we have the IAS recommendation, and we also have this real-world evidence suggesting that there's real benefit to patients to using this medication. I do want to end by talking a little bit about lenacapavir. Lenacapavir is a capsid inhibitor, a newer medication that is being studied primarily for multi-drug resistant HIV and for prevention. It's not yet being recommended in first-line therapies for HIV, and we'll talk about why in a second. In the Capella trial, this was the Capella trial here that looked at lenacapavir. It's an interesting trial because they only enrolled treatment-experienced patients with multi-drug resistance. And patients were actually randomized 2-to-1 to receive lenacapavir or placebo. But then actually later, they then got lenacapavir in the placebo arm and just demonstrated that viral loads decreased faster in the people who got lenacapavir earlier. Essentially, the idea was these were people with multi-drug resistance who did not have a lot of treatment options. So giving them any drug that would demonstrate reduction in viral load was actually demonstration of success. And so it was not necessarily a randomized controlled trial in the way we think of other things. They also randomized people to injectable or oral len, which is interesting as well. And both of them did work. And then there's the 26-week trial of daily, weekly or daily, 26-week trial of daily in combination with oral antiviral therapy for initial treatment of HIV. And this was the lenacapavir study here as well. In the interest of going way over my time, I'm not going to talk in detail about this, but just know that lenacapavir was successful. It clearly works to reduce the viral load. And the current package insert for len recommends it for people with HIV infection, heavily treatment experienced adults with MDR, HIV-1 infection, currently failing their existing antiretrovirals. So this is not a first-line treatment for HIV right now. It's to be used in people with multi-drug resistance who don't have a lot of other options, again, because we don't get cross-class resistance. And, Chloe Orkin wrote something that was really very accurate. These are undoubtedly promising results when the study first came out. However, lenacapavir needs a long-acting partner if it's to deliver on its promise of being part of a complete long-acting regimen. It's an every 6-month drug that we only have one every 6-month drug. There are people who have rilpivirine resistance that are being put on injectable cabotegravir plus lenacapavir, which is amazing. It's giving an injectable option to people who may not have had one otherwise, but it's not taking full advantage of lenacapavir because you still need to go on the injectable cabotegravir schedule. You don't take advantage of that every 6-month injection. And so while it does give us another option, it's not going to really be used in practice until we have a friend for it that's also every 6 months. In terms of what's on the horizon, there are some other long-acting agents. Islatravir is still being looked at for HIV treatment. They dropped the prevention arm of that because of some decreasing white counts, but it's still being looked at for treatment, and that's a once-a-week or once-a-month oral agent. Broadly neutralizing antibodies, either alone or in combination, are being looked at as well. There's new formulations of existing drugs. So what if we could do a longer-acting cabotegravir, and every 6-month cabotegravir that could then be paired with lenacapavir is being looked at. And then there's several novel classes in phase 1 trials some have moved to phase 2 now that are on the horizon. And so with that, I'll stop talking now and I'll turn it over to Katrine, who will tell you a little bit about Alea.
Thank you. I think that set us up very well because the project that I am going to talk about is Alea. It's called Advancing Long-Acting Injectables for Underserved Populations. It's a 4-year HRSA-funded SPINS project, a special project of national significance, which I always like to say out loud. When it was funded, we wrote it to say, we're going to be learning from the first available long-acting agent, which is the combination of cabotegravir and rilpivirine, as you just heard. But we're also going to be thinking about how what we learn from this experience can help set us up for those longer-acting combinations that are hopefully coming in our future. So what do we do at Alea? We develop resources to support clinics in rolling out ART programs that are specifically focused on how to introduce new regimens and new innovations without further exacerbating disparities. And in fact, using them as tools to decrease disparities or enhance equity, one might say. We also provide longitudinal technical assistance and implementation coaching to 8 clinics that we selected from a pool of about 50 applicants that are spread across the US. And then we synthesize the lessons that we're learning from doing this support and from the clinic's data and synthesize and publish not only in the academic literature, but perhaps more importantly, present at programmatic conferences and share our resources in webinars for Ryan White programs across the US so that they can learn and perhaps accelerate the pace at which they're going to adopt ICAB-RPV or future regimens. Oops. So who is Ally Up? You see here, there are 8 of us. There are actually, I think, a few more people have left who are at Columbia University. Then we have our colleagues at the Southeast ATC, at Vanderbilt in Nashville. We have Brian Kuttner, a familiar face at Einstein. We have the New York City Department of Health colleagues, and we have Dr. Golub and colleagues at Hunter. And so that's a lot of folks. It's a big project. And there's a lot of coordination, and folks are working on different pieces of the project. But the folks that were pictured on that slide, we come together about once a month to make sure the project is in alignment and that we're serving the clinics in the way that we want to advance the work. So this map shows the 8 demonstration sites. You see that it's spread across the country. As I noted, we had about 50 applicants to the project, and we selected these 8. We were very intentional about selecting clinics that were varied in their type. So we have health department affiliated clinics. We have clinics within AIDS service organizations and CBOs. We have a clinic within FQHC, at a social safety net hospital, and then 1 academic medical center. We had a lot of academic medical centers apply, and we specifically chose to include only 1 because academic medical centers usually figure it out by themselves, do not need as much support. So we included 1, but partly because we anticipated that they could act as mentors or sort of teachers within the project as well. Each of the clinics got $90,000 a year for 3 years for a total of $270,000. It's enough money that they can maybe hire someone to work part-time on this project, but not so much that they come to rely on that money to keep services going after the end of the 3 years. We require them to have a project champion identified in the application and include sort of why this champion was actually going to be effective in that role. They had to be someone who had decision-making authority within this clinic and had to have some sort of history within the clinic to be able to promote change within. In the first 3 to 4 months of the project, the New York City Health Department led public health detailing for these 8 clinics and we used it as a way to understand where each of the clinics was in their progress towards implementation, and basically essentially used it as a needs assessment. We are now in the 3rd year of collaborating with our clinics and in the 4th year of the project. We also have a project advisory board that I really want to call out. It is made up of patients, clinicians, pharmacists, social workers, and folks who have both personal experience either delivering injectables, taking injectables, or discontinuing injectables. We meet once every 4 months, and they really have become a sounding board for us when we're thinking about what do we want to do next. How do we need to refine resources to make them more useful? We really have come to rely on them heavily in the course of the project. So Ally Up delivers what we call strategies. We have 6 strategies pictured here. They've actually grown in number since we put together this slide. We provide technical assistance to sites about how to use the resources we create and address implementation challenges. We co-develop protocols, written protocols with the sites, and then use the feedback they give us to refine our own protocol template, which I'll talk about shortly. We build provider capacity through in-person training and also e-modules, e-learning modules with CE credit. We highly encourage community engagement activities, and we ensure that the budget at each of the sites has dedicated funding for this activity. We have a robust monitoring evaluation plan, and then we also facilitate cross-site learning through in-person convenings where everyone comes together and communities of practice. We're going to talk about these 3 things today. I'm going to talk about the protocol development. Delavet is going to talk about one aspect of the monitoring evaluation, and Nadia will talk about one aspect of community engagement. So Sarit Golub at Hunter developed a protocol toolkit to jumpstart clinics' development of a standard protocol. And the first thing we had to do was figure out sort of buckets or components that would need to be included in the protocol toolkit. And here you see the 5 buckets we landed on. They can be grouped differently, but basically we needed some part of the protocol to talk about how to engage patients. This is about making patients aware that this is a service that's available at your site. We have a second component about navigating coverage and cost, which is potentially the most complex part of this process. We have a section around procurement and storage, prescribing and administering, and supporting retention. So the protocol has 5 different sections, and in each section, it has 3 different pieces. The first is an overview, and what you see here is the example from prescribing and administering, and it's a 3-page document, and it lays out the rationale of why it is important to have this part of your protocol. Now, having a part that's about prescribing and administering is probably cannot, every protocol would have that. But the part about educating all your patients may be more unique. What this does is it shows what it is, why it's important to do, and key decision points that you'll have to make about how to organize that work at your clinic. Who is going to do that work, when in the workflow, or as the patient moves through the clinic, when that part of the work happens, how it happens, what kind of training, suggested methods for documentation, suggested performance measures, and then also a section on health equity considerations. So each of the 5 components has an overview document like that. Then there are worksheets that map onto the protocol and the overview. And it's basically something where we imagine stakeholders at a clinic sit down together and fill this out together, have discussions about, in this case, what the eligibility considerations should be. Jason just described what the package insert says. But of course, now we're sort of pushing the envelope and expanding who can get access. And so that's what the considerations column is here. It's all intended to guide discussions at the site. We are not deciding anything for them. We're just asking them to make decisions and guiding them how to do that. Lastly, there's the protocol template itself. This is basically a fully written protocol that clinics can just edit to meet their needs. So the idea, and if anyone has ever heard Sarit talk about this, the idea is that nothing is scarier than a blank page. And so we give them text to start, and they just edit it to meet their clinic needs. We also, that's all I'm going to say about the protocol. We have a lot of other kinds of resources that we've developed, resources for patient education. Everything we have is at least in Spanish and English, but we're also working on other translations as those needs arise. The staff capacity building resources, we have a quiz time project that was led, the development of which was led by the Southeast ATC, which is sort of an interactive, one question is sent to you by email or text message every day, and then you reply, you get to choose an answer, and then it has a detailed explanation of why that answer is right or wrong. And then a second capacity building tool, which is a self-paced e-module. I think in all there will be 8 of them. And the first one is available now, and the next 3 should be coming out this month. These are all available on the Southeast ATC website. It should also, all of these resources should be available at Target HIV. It is under maintenance. It has been under maintenance for months under the current administration. So if you're interested in accessing any of these, please email us instead at the email. All right, I will now turn it to Delavet.
Thank you so much, Katrine. And as Katrine mentioned, one of the activities within the project that we surmised would be helpful in supporting introduction and the speed at which they're introduced is actually the intentional aspect of monitoring, and it should say monitoring, evaluation, and learning. And so we really, so I'll talk through our process of how we established the monitoring, evaluation, and learning structure within the ALIAP project. So the rationale for this begins first with just understanding how important data are in supporting decision making, and people need to see it from the inception and development of those data points. And so we really feel that in the context of ICAP RPV, or that contributing to the ending the epidemic, implementation of equitable outcomes is critical. There are some determinants that are fairly widely understood at the client level, and they could include various types of socioeconomic markers, behavioral factors, and then logistical factors that influence the patient or client. There are also health system factors to consider, that may be the geographic location, policy setting that influence what and how a clinic might operate, the type of facility, their own funding level, and the workforce structure are some of the considerations. So in the context of ICAP RPV, we really wanted to understand first what people were collecting, and really trying to decide how we would define and operationalize variables that were important in assessing whether in the introduction there is maintenance of safety, effective and equitable delivery of ICAP RPV, which was the mission of the project. And also really trying to understand what might be context-specific indicators that may vary across the different facilities with which we're working. One of the key things for most people who work with monitoring and evaluation data, it often comes up in aggregate. So while it starts at client level information, typically when we think of M&E data, it's aggregate level, and part of the challenge is that it becomes really difficult to make attribution from aggregate level data. So with that understanding, one of the things that we really worked with the clinics to figure out is how can we actually get client level data to be able to support the understanding of how ICAP RPV is being rolled out. And from prior experience that we've had with other projects, we know that early stage introduction and client level monitoring and evaluation is a really critical aspect of learning, and to create that environment of sort of iterative learning. But there are challenges. So with aggregate data, there are less resources that is required to do it, and you can get that information much faster, and people are often familiar with how to do it. With the client level, we have better validity about where we might have misclassification of information, missing information, and an understanding of sort of like precision about whose needs are being met, where the gaps are arising or are not being addressed. And it also, as we're learning in the context of a learning health system, gives us the opportunity to start to think about what should be standardized and what should not be standardized. So that's sort of part of it. And then maybe the biggest bear to wrestle in M&E data is actually duplication of information, and how to actually go through a process of deduplicating information from a data quality standpoint. So these were the selling points that we really thought about and talked through with the sites about how we wanted to do this. And so the objectives were, in the context of the MEL approach, was one, to co-develop a clinical monitoring and evaluation metrics that would be used, that allowed one, for context-specific indicators of health equity, two, the feasibility of measuring these equity indicators to really inform learning. The second was to then implement this client-level monitoring and evaluation learning to assess whether ALIAP was actually achieving its goal of supporting equitable introduction of long-acting injectables. The third objective was then to build capacity at sites to be able to collect, report, and utilize the data that they're getting, and then to describe the strengths and challenges with collecting and utilizing. And there certainly were some good things, but I think if the sites were all here, they could give you a bevy of challenges with this exercise. So I always try to say that we're trying to use data for good and not evil, but in the process of data collection, it might not always feel that way. So in the co-creation process, we actually met with the teams first. So there were representatives at the sites who really could talk through, one, what indicators they were already collecting, what was their process by which the data are generated and measured, and how could we actually start to utilize what they're already collecting to be able to characterize reach, equity, fidelity, safety across the clinical cascade. And even the question of the clinical cascade, in the interest of time, I can't talk through, but we sort of had a generic schema of how we thought the flow would work, and then went through an entire process of understanding from the site's perspective whether how they collect the data actually would match or map on, because that would inform what's an indicator that has the same denominator that we're conceptualizing, and where the numerator might be, and where there might be misrepresentation in data. And anyone who's sort of dealt in the M&E land know there's nothing more challenging to find that you have a larger numerator than a denominator. So in any case, so we went through this process that was iterative with the sites to really understand additional issues about data access, data use, support for being able to manage the data for transfers, and issues around data privacy and protection to be able to do that. All of that culminated into what we called a monitoring and evaluation reference guide. And within that reference guide, we then also had an Excel-based tool that the sites used to be able to incorporate their data. And sites did it initially quarterly, so that we really had an ongoing and as close to real-time understanding of what they were collecting, with the intent that once we sort of had a more stable understanding of the data collection, the intervals between which we collected data would be wider so that it's not so burdensome on the site. So on the left-hand side here, I have just a picture of the front of our reference guide and dates in which we've had different iterations. And on the right-hand side is sort of the convergent schema of the clinical cascade that everyone agreed we could do a reasonable job of measuring these indicators. And as you can see, I won't spend too much time walking through it, but it really starts with the number of people who are served in the clinic and sort of walks through the process by who is served, who's living with HIV, whether or not they're on any antiretroviral, and then whether or not they're counseled. And oh God, I don't have my glasses, forgive me, and I've a bit long in the tooth and dim in the eye, so I can't see everything, but it basically goes from being counseled and then determining whether or not the individual is eligible for ICAP RPV, and then through the cascade of deciding if they're offered, if they accept, if they initiate viral suppression, and sort of the classical things we think of through the care and treatment cascade. I could actually, in the interest of time, could have showed different iterations of this, because where we started and what this looks like is actually a bit different, because we had a lot of discussion around the front end of how that order of who gets to know, when they get to know, what we considered counseling, who decides they accept it or don't accept it, what are the reasons why it may or may not, an individual may or may not receive an injectable, and really trying to classify that, because within that sat several issues around access and equity. So here then we mapped on in the reference guide, what you would see is a clear description of each of these indicators that defines the reason for it, what's the numerator, what's the denominator, how we expect to measure it, and the interval. And then we had the disaggregations, which were essentially the equity metrics that we had identified through the sites. Across the sites, we had 9 metrics essentially that all sites sort of agreed they would be measuring. So then we looked at sort of the quality of the process. That's one initially, because it takes quite a bit of work to get all of this together. We just wanted to get a sense of how long and how much work it took the sites to get us the data. So we called it sort of the timeliness of being able to even get the information to us. Then we looked at the quality of the information. Where are they incomplete and why are they incomplete? And then there was an iteration back and forth with the sites, which can be quite aggravating, but hopefully in the long run, rewarding. And then there's sort of the validity of the data in terms of, what we see as certain types of error patterns. And as I mentioned, this continued to be an iterative process with the site. So we collected the data and sort of looked at it in aggregate back with them and talked through the issues. So I'll share, just some of the snapshots that we have from the first year of the learning and then build on there. So here is just a table that sort of shows the 8 sites that we ended up working with. And so you'll see the first is sort of the volume of people with HIV who are served at the clinics, and they range in quite size of the volume, from sort of as small as 92 people to clinics that were serving nearly 3,000 individuals as sort of active patients at the time of the inception of the monitoring process. Then there are the portions of people who are on treatment within that population, and then those who had been, who were either already on ICAP RPV or were initiated on ICAP RPV over this first year of the observation or rollout of the M&E approach. Excuse me. And then who started, because some clinics had already started people before we were on there. So the metrics represent sort of retrospective and then within the context of ICAP-RPV. So then we see the distribution of patients now just newly initiates in the context. And we split it up by volume because that was an interesting thing that emerged early on, which is that the clinics with much higher volume tended to have a lower proportion of people who were emerging. And I call it the demographic fright. I think anyone who works in like PrEP programs, for instance, and you work in, settings where HIV burden is fairly high, the big concern is that if we sort of told everyone about this prevention, that we'd have swarms of people coming. I think with the exception of GLP inhibitors, there's nothing that any human being is running for that quickly that is called a medical intervention. Nonetheless, it is sort of the nature of how we think we should approach it. And so this is the pattern that we saw here. And then another really important thing is because this is an injectable and often patients are coming in need to really fit within this window, we really wanted to understand the fidelity for being able to stay on schedule. And so this is another heuristic that really just captured what proportion of patients were coming within the window to get their injectable, which was either monthly or 2 monthly, depending on the schedule of events. And what you'll see here, sorry, I went too quickly before completing the description, is that the majority of patients actually came in on schedule and only a few were really classified as late. And even late was something that ended up being a big discussion point about what truly is late based on what the insert described as late and what the experience might be. And then other metrics about how do you even count the schedule? Is it from day one all the way through, or is it sort of like modified based on the last schedule that sets the date for the next window? So these are lots of measurement issues that when you sort of roll things up in aggregate, it would be really difficult to deconfound, and was really important to be able to have that those individual level data to really gain an understanding of how what would be an emergent practice for measurement that would come in. And then as Jason sort of set up and then Katrine talked through, is that there's sort of like where we started with who can and should be using ICAP-RPV, and then how can it be expanded to ensure that there's equitable coverage for those who are most in need. And those would include people who have challenge reaching an aviremic status because of various reasons, whether they cannot or do not take oral pills and so forth, or could not establish viral suppression through other mechanisms. So one of the other indicators where it's really trying to understand what is the experience of people who start virally suppressed as the trials initially had shown, and then also people who start off with some level of viremia that was not necessarily the initial indication for using this product. Okay. Sorry. Okay. So here we I just have a table that highlights some of the indicators by equity measures. So one certainly was age, that is classically reported by most sites. So we look at the distribution of the volume and the people on ART and on ICAP-RPV by age. And this was one where we discussed with each of the sites to see whether or not the uptake that they're seeing varied by different age bands. And for some sites that highlighted where they were doing as much of a job with younger people than they would have liked to, or with other subgroups. This heuristic then sort of shows the 9 equity indicators that we disaggregate the entire clinical cascade by. And this is a bit old, and I call it my Go Green slide, which is across all of the sites, everyone could measure age, gender, ethnicity, race fairly well if they got it to us. And I'll acknowledge that we still do not have data from all the sites. So that's part of the work of really being able to even get the information. Then other things that sites considered important was employment, housing status, poverty level, immigration status, whether English or another language was the primary language used, history of incarceration, and then there may be other context-specific indicators. What we realized is that even though different sites identified different metrics as being really important to their context, when we talked across all the sites, these were really important to everyone. So the agreement was, now can we decide whether or not, one, your health system already collects these data and if these data would be accessible and available. And we sort of had this dashboard of really understanding why would the data not be accessible, not available, and how do we support sites to be able to get to these data so that we can have a comprehensive understanding of what's happening across the sites. The other aspect of sort of talking through the indicators was also recognizing that no single disaggregation was what was important to our sites. And actually, people might have said they were interested in understanding what's happening with young women or older MSM or people who were incarcerated and had a history of substance use. So really trying to understand what the intersectional identities were that could also inform equity and not just breaking it down by a single disaggregation. And this is where we really got to thinking about, well, how can we make the data more flexible and usable for sites? And that sort of led us to developing this dashboard that would allow sites to be able to toggle across these different measures. The first part we did was entirely through data transfer in Excel sheets. And now these data have been moved into this Our Shiny dashboard, which allows users to do a number of things. One, it helps the clinics to see clearly and understand their HIV treatment data with a focus on long-acting injectables. Two, to track the progress towards the program goals that they have set. And I'm skipping through a lot of details in the interest of time, which is how did they set their indicators? What what proportion of the clinic they think should be or could be or would benefit from being on ICAB, RPV, so on and so forth. So there are lots of things that sort of is baked into establishing these purposes. And then the third being then to identify gaps in care, especially disparities among different demographic groups, and then really then thinking through how do we address the gaps that are recognized. So the process for the dashboard was also a co-development dashboard. We've had it through a number of iterations, and happy to sort of send the link that some people could see more of it. But and really we came down to about four evaluation criteria to really think about the dashboard. One, is it useful to you? So how we visualize the data in the dashboard, is it clear and helpful? What are suggestions of how the user would want to visualize the data? The other was functionality, which is, how are the variables assessed? Do you still agree on each of these across the description within the dashboard? Then applicability. Many sites already had their own dashboards or have their own data system. So what is the purpose of this in addition to what you already have? If you have nothing, is the juice worth the squeeze by using this one? And if you have something, what is the value add of these data? And then just aesthetics. We know that people like to look at beautiful things. So when you open the dashboard, do you feel joy in the information that you see or not? And so here is I'm just going to show quick snapshots of the dashboard. So a user comes in, and this is sort of what they see on the left panel. It allows them to sort of click across the various steps in the cascade. And then you start off first with like selecting the sites. Sites are very interested in understanding how we're doing overall and getting a sense of how they're doing in comparison to other sites. So so the site can come in, see sort of a general view of how the program is doing, and then select their own specific sites, which will allow them to see information across the cascade and overall and broken down by the 9 indicators. It has the total volume of people see in the database right now, and that sort of is captured in the general information. Then once you sort of click on a specific indicator and its disaggregation that you're interested in looking at, the user has the ability to either download the picture, so they immediately get a figure, or you can download it in a table format. And here I show sort of what the downloaded version looks like once you pull it down. We thought this was also useful. Many of the sites have to generate reports. So, the principle with M&Es, if it goes up, it must come down. And so this is our perspective of how it comes down so that you have sort of useful information that you can use forward. Then the next panel on the left-hand side gives a walkthrough of the various indicators, as I mentioned, and same thing, where the user has the capacity to get disaggregations. And then we have sort of estimates, and where errors around the estimates are reasonable to include, we incorporate standard error bars as well. And then I would say the last of it is then looking at, we have what we call the data explorer, and this is where the user is really able to then have different combinations to really look at the intersectionalities. So in this case, if you were interested in understanding, how the site was performing in assessing people who were interested in using ICAP RPV and wanted to look at it by race and age, and you can look at all the age bands to see sort of where their variation, and if it feels too voluminous, and this was one of the things that we heard from sites, was that, sometimes it's almost too much data, and it's of course, and from trees, is kind of challenging. I think for many of us who sort of sit in a data space, it was like, yes, of course, complete. And some people were like, no, too much. So this gives the user the ability to sort of zone in on certain things that they're interested in. At the same time, what you won't see at the bottom is that we also wanted to ensure that there's good data integrity, which is not to slice and dice the data. So if you took one band and you just sort of talked about it, you need to really understand how it fits in the whole always. So the picture might show one, but the table will give a full comprehensive description of the data distribution. So that's sort of, how we've walked through the process with the monitoring, evaluation, and learning. And in summary, I'd say one, we've really successfully co-developed a client-level clinical monitoring, evaluation, and learning approach with a resource guide and dashboard that produces context-specific social determinants to track the possible inequity or equity in delivering ICAP RPV, and have identified 9 social determinants of health that was really consistently sources of interest across all of the sites. Collecting the client level data is feasible, but there were notable challenges that I would highlight. One is really trying to understand what the health information infrastructure that is at each of the sites, data access and availability issues, the staffing for data management to be able to pull, organize, report the data, and sort of make modifications as needed. Regulatory support where it's needed to ensure that issues around privacy, access, and concern are addressed. We were able to use the data to describe, as I showed, reach, fidelity, safety, assess, and there are tons more other analyses that can be done now that we have these data and understand what might be emerging needs to really use the data to be able to understand and describe. Sites were able to also develop the capacity to collect and report, even those that felt like they could never look at information did. And happy to share some of those experiences. And then in some instances, recognizing where there are information that were not readily available, but then they decided was really critical, really started to either augment their data collection system or track where the information was already being entered, but didn't show up as an output. So I think these are some of the where we really left things. There are other markers that were beyond, the capacity of individual level monitoring that really sits at the site level and at the sort of the jurisdiction level of where sites are. It's a sort of next step, but at least at this level, I think we were able to do a reasonable job. Thank you.
Hi, so today I'll be talking about a quality improvement project that we undertook with a few of the clinics in LAF. And so, the motivation for this QI project, QI is a concept that's very familiar to all of the clinics. They've all done it. However, they don't always, take into account patient and staff input. Oftentimes it's, a top-down approach. And sometimes there's not enough attention paid to testing, making small tests of change, evaluating those changes for impact, and then iterating as needed. And so we wanted to bring that level of rigor to the QI work that we were doing with our sites, and also use this QI as an opportunity to find a different way to engage with patients that they were serving. So we brought in consultants from Population Health Improvement Partners. This is a group based in Raleigh, North Carolina, and they have a lot of expertise in quality improvement. And in particular, they've used 2 different strategies to engage patients and staff that we are really interested in bringing together and trying out in this context. So 3 sites volunteered to participate in the supplemental intensive quality improvement project. And the project entailed hosting PHIP, their LAF TA coach, and either Katrine or I for a 3-day site visit. And during that site visit, we would facilitate 1 to 2 2-hour story sharing sessions with patients to gain patient insights, a reflection session following that, and then a half-day narrative change session with clinic staff. And then we were going to use the insights from that experience to inform a quality improvement project, and then implement and test that project through PDSA cycles. So what are these story sharing and reflection sessions? So the story sharing sessions were an opportunity for patients and community members to come together and share personal stories about their experience living with HIV, accessing HIV care, their experiences with injectable, if relevant, and share it in a safe, supportive space. And then after they shared their stories, they were invited back for another session where they reflected together on common themes and barriers and facilitators to thriving with HIV. And then they worked together through a guided discussion to identify possible solutions to the challenges they faced. And this was kind of the seeds for developing change ideas for the Quality Improvement Project. So to prepare for these story sharing sessions and reflection sessions, we had a number of preparatory meetings with the sites in the months leading up to the site visit. And we discussed lots of important details, including the location of the sharing session. So it was very important that, the sites chose a place that was private. We encouraged them to not do it at the clinic so that people would feel like they could speak frankly about their experience. Also, for people who are out of care, we wanted it to be a place where they felt comfortable visiting. We also encouraged them to, think beyond their usual recruitment strategies. So we didn't want, the CAB that they always bring together or the same voices that are always kind of sharing their perspective. We really wanted new ideas to hear perspectives that aren't always uplifted. And also to bring in patients that aren't necessarily seeking care at their clinic, to understand maybe like, why are they not coming to that clinic and what ways they could serve their broader community. We really focused on accessibility. So we provided them with funds so that they could provide transportation and childcare, food, and incentives for the people who attended these sessions. We held them in the evening, or we had a mix of evening and daytime sessions to ensure that people could attend if, not during work hours. And then we required that there be a mental health counselor present because they're going to be sharing really personal stories, potentially bringing up traumatic experiences, and we wanted to make sure that they were supported. And then we spent some time thinking about, well, what kind of prompt, like how are we going to kick off the story sharing session? Like what kind of story do we want? A story could be really broad, it could encompass many things, or it could focus just on injectables. And what we landed on was we started with a general prompt about their experience with HIV and seeking care. And then we had some more specific prompts about injectables because this is a project about injectables, but we didn't want to focus on that alone because we understood that that might just be one piece of someone's HIV journey. So we had 5 story sharing sessions across these 3 sites. They had them at a community space that was attached to the clinic in a conference room area, and then one clinic chose to do it at a local community center. They really did a great job recruiting really diverse participants, and they used really different approaches than they normally use. So they, did personalized invitations. So instead of just posting a flyer in the clinic, they had, the social worker or providers who had really good relationships with the patients reach out to them personally. They called them up, they sent them text messages. They also did outreach through different, networks. So, at one clinic, for example, there is someone on the non-clinical staff who's really involved in the ballroom community. And so he really invited a lot of folks to come, and they're not people who typically participate in, these in the CAB, for example. And so it was really important, a really effective way to bring in new perspectives. And so, what did the story sharing sessions look like? So the folks arrived, we, laid out all the food, we, broke bread, we introduced ourselves, and we explained why we were asking them to come share their story. Sorry. And then we spent a good amount of time going over the ground rules. It was very important that this was a safe space and that privacy was respected. And so, we went through all of this so that people felt like they could share and that what was being shared would stay in that room. And then we went through a series of like introductions and icebreakers. We checked in with how everyone was doing emotionally, and then we also did some grounding exercises before we showed the first prompt. And we asked folks to share stories about what has it been like living with HIV? What are the ways that it has affected your life, both big and small? And some people started big and some people started small. And we also made sure that each site had a person prepared to share the first story in case people were feeling nervous. And we had note cards around the room in case people wanted to first jot down their ideas before they shared. And it was an incredible experience. It was really powerful. Many folks had really never shared their story before, or they'd only told maybe one person, like a trusted partner or a friend or family member. Um, Many people, expressed this was their very first time ever saying this out loud in public. So it was a very powerful and cathartic experience. And after they, everyone had time to share their story. And afterwards, people offered a lot of support. But what was really important was that, the staff that were there, the clinical staff, they were quiet. And we as moderators, we were very quiet. This was not a situation, not a focus group where we were probing or asking follow-up questions. It was really a chance for people to share their story as they saw fit from start to finish. And that was just a very empowering experience for a lot of people. And yeah, so I think that was really powerful. And then after we asked that open-ended question, then we focused a little bit more on their experience receiving HIV care and treatment, at this clinic, at previous clinics. And then we asked them about their experience learning about accessing and receiving injectable treatment. So here are some of the things that we learned from these story sharing sessions. Firstly, many people shared that they experienced significant, stigma in their life, both external and internalized. People describe, having, family members not willing to share food with them, people throwing away plates and utensils after they've used them, um, losing friendships because of their status. Also, people shared internalized stigma. Some of these sites are in the South. A lot of these participants are deeply involved in their church or grew up in the church. And so they felt, just a lot of shame and conflicted feelings about their gender identity or sexual orientation. And that was a source of conflict for them. They also shared that there's just really high levels of misinformation in their communities, and this just fuels the stigma. And so that was really something that has been really difficult for them. Another common theme was that folks just felt really, really lonely, and there was a strong desire for social support. And this was happening in real time. So people were sharing their stories, and there were folks really kind of at all ends. So some people were newly diagnosed, other people had been living with HIV for a long time and had been through, many stages of that process. And there was a real, folks who had been living through this really, there was a desire for them to like mentor people who were just experiencing this for the first time. People were exchanging phone numbers, and it was really powerful to see this community kind of form right in front of us. And then people were, had various feelings about whether it made sense for them, to disclose or not. So some folks were very private, they had the view that unless I'm having sex with you, you don't really need to know my status. And then we had people who were very public about it, folks who shared on their social media, their social media accounts. There was someone who was like a representative for a drug company who's been in commercials. There was someone, who was an activist. So we really had a range of people kind of sharing their experiences. And it was, I think, really powerful for folks to be like, there's lots of ways to live with HIV. There's no one right way, and we all can support each other. And they found really strong community in that. In terms of knowledge of injectables, everyone had heard of them, but not everyone had heard that their clinic had them and that it was a possibility for them. And this was very interesting because these 3 particular sites all have adopted a universal education model. So it was really interesting, I think, for the staff to hear that their message wasn't reaching everyone. And so that kind of caused them to think a little bit. And then the people in the room really enjoyed and were very curious to hear about real life experiences of folks who were on injectables. And, that was much more powerful than anything that they were getting, maybe from their doctor and a commercial. And so there was a lot of curiosity about injectables. And the people who have tried it were really pleased with it. There were folks who, experienced side effects and have to stop, or who had failed treatment, but they were all happy to have had this choice. And there was just like a lot of curiosity about it, and some people, you know, expressed having some concerns or things that they wanted to learn more about. And of course, there were some people, you know, who were just like, it's not for me, which is expected, right? Some people don't like needles. Some folks don't want to have to come to the clinic more often. For the clinics, this was also a really valuable experience for them. So when we first introduced this idea, they were, you know, a little skeptical. They're like, you know, we already do a great job with community engagement. We really know our patients. They tell me everything. But they were really kind of blown away to hear stories and experiences that they had never heard before, even from clinics, from patients they know really well, you know, for decades. And so that was really powerful for them. And they were really kind of unaware of how much and the ways in which some of their patients were struggling. And so I think this really prompted them to think about, like, how can we engage in our community in different ways that can elicit some of these other experiences. And so, for example, you know, as part of Ally Up, we provide funding for these clinics to conduct community listening sessions. That's the first activity they did for Ally Up. But, you know, one clinic said to me, like, oh, you know, it's so interesting. You know, we've been doing these community listening sessions, but during these sessions, I talk and they listen. And this really kind of opened my mind to, like, I need to be listening a lot more and talking a lot less, you know, and also the power of incentives in food, providing a personal invitation as opposed to just kind of a broad email blast. Having how important it is to have a safe space for people with HIV to come together and just share their experience. One clinic had, you know, actually had a buddy system they already built. It was a social support system, but nobody knew about it. And so this was a chance for them to kind of reevaluate how they were promoting that activity. Okay, so we're almost out of time. So basically, there was also a reflection session where they came back and kind of reflected on what they learned. And then we had an experience with the staff also being brought in and discussing kind of common narratives and what were harmful narratives that were standing in the way of how they were delivering care. And so now basically we're in the phase of using all this information to develop quality improvement projects. Those projects are then going to be implemented, and we're going to do small tests of change, and those will be reported out back to the patients who developed the ideas, and then also to other sites at the next convening.
All right. So that gives you a sense of what we've been doing for the past 3 years. One of the things that we are supposed to do is synthesize it all. So what we've told you is a lot about process and a lot about the kinds of activities we've been doing. And now in this 4th year comes the hard part in some ways, which is figuring out how to distill this into lessons that can be applied to other clinics and also for the field of implementation science. So I'll just say that we have throughout been measuring sort of classic implementation science outcomes at the strategy level, like how acceptable, appropriate, feasible are the strategies that we are doing to the clinics. Then there are implementation outcomes about the injectables themselves. Are they being adopted by the clinic? Are all providers or only some of the providers prescribing? That's a measure of penetration. And then who we're reaching and how representative are those that we are reaching. So those are another category of outcomes. And then because we have date-based data, we're able to look at the pace of implementation. And also we have a costing activity. So we also are able to report on the cost of implementation. So we're measuring all these things and are now in the difficult stage of trying to understand how they all connect to each other. So we have measures of the outcomes. We know what we did and what the clinics are doing. And now the difficulty is figuring out the causal pathway, right? Why is it that it's working in some places better than others? What are the mediators or moderators? What are the underlying conditions that are causing these strategies to work better in some places, worse in others? So that's the work that we have ahead for the next year. And I will end there and invite discussion and questions and hope we can answer them.